around the world, which is sharing bandwidth. So welcome everyone. Today's learning community is going to be a focus on the population that you serve, specifically those who might be involved with the criminal justice system or have some level of criminal justice involvement, either in their present time or in their history. We're really going to focus a lot about some of the other experiences that folks who've been involved in the criminal justice system may experience. And so the purpose of this training is to kind of give you guys some background as to how complicated and how overlapping a lot of issues and challenges may be for individuals who have been involved with the criminal justice system, just to give you all a little bit more background. And also, hopefully, it's information that you can share with coworkers, with your peers, with even educating landlords out in the community, because I know that you guys, in providing service to your clientele, you're also doing an awful lot of advocating. So this is going to be part providing you guys with maybe some information you didn't have before, and maybe some techniques to work with individuals who you may see as challenging to engage sometimes, and also some information that you can utilize to advocate on your client's behalf as well, or at the very least to better understand their experience. So just a little bit of housekeeping for those of you who have attended our trainings, our learning communities before. You know that, hey, we love chatter. We love you guys to talk if you can, because that means we're not doing all the talking, and we really appreciate that. So if you do have a question, please feel free to open up the chat box and type it there. I would love it if you guys use the chat box rather than Q&A. Just because if we stick to one modality for you to type a question in or something, it's just a lot easier for us to just have to pay attention to one pod. So type any questions you have or comments into the chat. And if you would like the mic, please let us know and we'll pass the mic and you can contribute. So feel free to ask any kind of questions or make comments as they come up. And just another reminder that this session is being recorded. It actually started recording as soon as I opened up the room, so that was the challenge that I was trying to work around. So when this is recorded and shared with all of you, hopefully we'll be able to edit out the first 20 or so minutes of dead air. Otherwise, we will provide you with instructions that if you would like to view it or if you would like to share it with other coworkers or anyone else, we'll give you the appropriate time point to start the video at. You will also receive PowerPoint accompanying slides as well to utilize for future reference. So without further ado, let me go ahead and get started by introducing my colleague, Ken Kinter, who I've had the pleasure of working with for almost 7 years. Well, I've known him for about, 15 years, but worked together for about 7. So Ken Kinter is my colleague. He works with me in the State Hospital Psychiatric Rehabilitation Project and also has a pretty lengthy career experience in interfacing with folks in the criminal justice system in both emergency screening centers and in inpatient forensic facilities. And me, I'm Dawn, and I have a lot of the supportive housing experience before I came to Rutgers. So we just kind of want to let you guys know what our background is. And because we are in a consultation role and a training role with the state of Washington, if you guys ever have any questions or want to bounce something off of us, you can absolutely reach out to us. So our learning objectives today is to go over some of the facts and falsehoods about forensic populations, the role of stigma, so external stigma and internalized or self-stigma, and what that can do to an individual in delaying their recovery. Intersectionality as a concept, so these multiple kind of layers of inequities and stigma and injustices that a person may experience as having multiple, as society views it, undesirable characteristics. Diagnoses differences between forensic and civil, meaning non-justice involved populations, and some of the challenges in serving this population. So I'm going to go ahead and turn it over to Ken now, and we're going to kind of volley back and forth throughout this training, but he is on now. So Ken, you go ahead. I'll advance the slides for you.
All right, thank you. I'm going to say good morning because we're talking to the Pacific Coast. So good afternoon here, but good morning there. Hope all's going well with all of you, that you're all healthy and safe. So speaking of healthy and safe, these images don't reflect that whatsoever. First of all, I hope you've all seen The Silence of the Lambs. If you haven't, please do. But the reason I brought this up was I've had two experiences where I've come directly up against this the topic we're going to be talking about, mainly the stigma around the forensic population. And I think when people think about a forensic facility, this is what people think. They think of well, maybe not Dr. Lecter, he wasn't typical, but somebody like Miggs or somebody in that sort of situation. And I think that's what the average person thinks. And then that's problematic because, as we're going to talk about throughout this presentation, what we think, the thoughts that we bring into a situation, impact our feelings and our behavior about it. I know I've been working with the Forensic Hospital in New Jersey for about the last 2.5 years. And I know that when I walked in there, I did before I walk in the first time, take a deep breath. Okay, here we go. Where's Miggs? Where's Dr. Lecter? And the way that the Forensic Hospital in New Jersey is set up, people go from their residential units past some of the offices into the programming wing. So I got to see the entire population go by on my first day there. And so I just stood at the door and watched. And what I saw going by was not what I expected to see. I saw a lot of people that were old, a lot of people that were frail, people that had obvious traumatic brain injury, lots of different things going on than what I expected. So my assumptions got challenged in the first 15 minutes because the picture that I had set up, which is probably more like the picture you're seeing than reality, got challenged right off the bat. And as I've been there now all this time, I can see many other reasons why people end up into such a facility and how that stereotype I had didn't really fit the situation. I had an identical experience when I started working in a county jail. I take that deep breath. Okay, I'm going to be working with criminals now. I've got to be on my guard. I've got to be present a little harder, tougher, face. I've got to have a whole different persona in this facility. And then 90% of the people that I saw in the county jail were the same group I had seen coming through the emergency room in psychiatric emergency for the 10 years previous. So it was really primarily the same gang. So I just want to call attention to that in the beginning, that what I thought I was going to be dealing with going in was almost completely wrong. Next slide, please. So some of these words were definitely some of the words that were crossing my mind in who I was going to be dealing with and the situation I was going to be dealing with. And to be honest with you, even though I'd worked in an emergency room for about 20 years, I went in with a lot of fear. And a lot of that fear was self-generated, and it wasn't based on objective fact. It was really based on my own, as I said, incorrect thoughts. Next slide, please. So this is sort of the CBT way of looking at the phenomenon I was just talking about. So in the pyramid we have here, we have thoughts at the top, particularly automatic thoughts. And then moving to the right, we have these feelings, and then the behaviors that come from them. So this is going on with us all the time. We very often have all these automatic thoughts that come into our mind about everything. Somebody might say, okay, it's 12 o'clock, it's time for lunch. That's an automatic thought. I'm not saying I'm hungry, I'm saying it's 12 o'clock. So we have these automatic thoughts. Some of them are positive, some of them are neutral, some of them may be negative. So what I put up here is this illustration of my process coming into the forensic setting. So I might come in with the automatic thoughts of, they're criminals, they deserve to be here, they'll hurt me if they get the chance. And then that leads to feelings of primarily fear, but also anger. and of course, anger and fear. We could have a whole talk just about the relationship between those two and how actually similar they are. Anger very often being a secondary emotion to fear. And then that results in, all right, I need to put up this tough front. Or maybe I shame them and I kind of reinforce that position that I'm the authority here. Look, you're the inmate, you're the client, you're the patient, I'm the person that's in charge, or I'm in charge of this thing that I can either choose to give you or withhold from you, depending on how you act. And this feeling of superiority. Again, we already have a power differential. And we're going to be talking about that power differential as we go. And that power differential is going to exist regardless of what we do, but the choice we have is whether we choose to reinforce that or whether we want to act with someone a little more therapeutically. And again, a word that we'll probably talk about is respect, and that whole idea of giving and getting respect is a very contentious issue. The other piece I wanted to add in here is on the left, the past potentially traumatic events. If you've worked in the field of mental health, or if you've worked in the addictions field, none of us are completely unscarred. We take on, we maybe many of us have been assaulted at one point or another, or put in frightening situations. We may also have been put in situations that are emotionally damaging, whether we've witnessed something or participated in something. So we all kind of carry around that little backpack of trauma around with us, both the stuff that we had when we came in the door, but then also stuff that comes with the field. How is that impacting our perceptions, our thoughts, our feelings, and our behavior going forward? These are some really good questions, because that may be guiding us, or it may be guiding coworkers or people around you, and then you have to deal with that. Next slide, please. So the previous one, my experience is that this little CBT triangle thing, people have a negative one or a positive one. We have the normal thoughts. If you think about how you're doing on a day where you're okay, you may think positive thoughts. I'm a good person, I'm hardworking, et cetera, et cetera. That feelings that come from that may be joy. And then your behavior may be compassionate and altruistic. The first example we gave was the negative one. This one is a little bit more the positive, the corrective one. And we'll get to this more as we go through the presentation. Maybe we'll even, if we have time, we'll look at it again at the end. So one thing that we've discovered in the research is that the people that we serve have experienced large amounts of trauma. They've experienced violence, normalized violence, I should say, poverty, and also this sort of criminal justice hierarchy. Even in a forensic setting or a correctional setting, there are different tiers based on what someone's offense has been, how long they've been there, maybe their comfort level with violence. It was surprising to me to see, even for example, to even see in the forensic hospital, the gang members, the high-ranking gang members, are at the top of the hierarchy. So that's an interesting thing to see. And as you can imagine, people with sexual offenses or child offenses are at the absolute bottom. So not only have they experienced trauma, violence, and poverty, they've experienced a biased criminal justice system. We'll be talking about that a little bit later. And then an important thought is how I treat people influences the risk of violence. There are a great many things about violence that we don't control. That's a whole other presentation. In fact, you guys may have already had that regarding the environmental aspects, the aspects regarding the client, interactional aspects. But then one of the largest things we control is how we approach the client. In our research, our colleague, Tom Bartholomew, has been very involved in inpatient violence, and he finds that authoritarian staff are actually the thing that correlate the highest with violence. So that's interesting. So
Ken, I just wanted to interrupt for 1 second. We got a question from Kit. She was asking if you could
go back to
repeat the hierarchy thing. Yeah.
So my experience, and I haven't done the research on this apart from anecdotally, but in every setting that I've seen that is correctional, there is a hierarchy among the clients, residents, inmates there. High profile people, celebrities, and gang members tend to be very much at the top of that. At the low end of that are people with sexual offenses, particularly child sexual offenses. So there's this existing hierarchy that's there. And then when new people come in, they have to find their place in that hierarchy. And that's where a lot of conflict ensues. Interesting enough, I've seen this in the male and the female populations that are segregated. I thought it was a male thing because we, stereotype, we like structure and, the hierarchy and all that, but it exists on the female units I've seen as well. It's an area that I would benefit from some additional research in, but that's something that for us to be aware of, because that's the environment that we work in. And to a certain degree, we are both within and outside of that hierarchy. But the point I was trying to make is there's already a pre-existing power differential. We as staff have a specific spot in the hierarchy, and it's good for us to know where that is, even if that's just perception. I'll give you an example. The first day I ran a group in the county jail, we're in the basement, and I'm in a room with 12 people who I don't know their backgrounds or anything about them. The officer introduces me to the room by saying, "This is Ken, he's the new shrink, and don't even think about taking him hostage because he isn't worth anything." And he walks out. Then I start group. So I knew my place in the world right away.
That must have been a little uncomfortable.
I'll add on by saying, by the time we got to our fourth anger management group, the officer who was supposed to be sitting in the next room looking through a window, and he was really doing crossword puzzles, by the third or fourth session, he was sitting in the group sharing about his divorce. I did not ask him to do that. That just sort of happened. So anyway, other parts of the joy of working in corrections. So I hope that covered it. If not, let's bring that in the Q&A because I want to make sure we get that.
Yeah, absolutely. And if there's any points we don't thoroughly get through, we can absolutely revisit them, because I think we always save time for discussion. So that'll be something we can do.
Right. So this version of the CBT triangle, we have these new automatic thoughts at the top, and it takes a while to repeat those, to reinforce those, to get those to stick, because those other ones have been around for a while. It's still okay to have a feeling of fear and self-preservation in a setting like that. Fear keeps you alert, keeps you from putting yourself in situations where you may endanger yourself, and recognize situations that are more violence prone than others. But then the behaviors change. Now it's communicating with respect. It's giving respect to get respect instead of, well, you will respect me. Let's start with that. Acting from a place of empathy and compassion, not treating people as less than because of what they did, their legal background. And what I say, people first. So like in mental health, we use the person with schizophrenia rather than the schizophrenic. And again, we don't hear lots of talk about inmates, or it might be a population that's forensically involved, instead of saying it's a criminal, the person's a criminal or something along those lines. Next slide, please.
Okay, I think I'm taking you over here. Oh, let me put my video on. Okay, and I'm magically at the beach. Yay, like how that works these days. So, excuse me. So thinking about what Ken just said, I'm going to just flip back for a moment here. So there's these ingrained thoughts that formulate in our head because of our experience, what we see in the media, what we see in movies. Ken started off this training with The Silence of the Lambs, which is one of my most favorite movies ever. It spurred me to get my master's degree in behavioral science because I thought I was going to be like Jodie Foster and be an FBI agent and all that. And I'm much happier here with all of you in Washington. But that being said, right, we have these ingrained thoughts, both good and bad, automatic thoughts that pop into our head. And we form biases because of those, right? Sometimes biases can be good. Sometimes biases can be bad. But we form these automatic thoughts in our head. And one of the things that I just wanted to pause at was what Ken had included here was, what is our own trauma around interacting with folks who are justice involved, or what is our familial experience? Some of us may have experienced a double whammy of trauma by having a family member, a friend, be involved in the criminal justice system, and also we could be a victim of a violent crime, right? Or be related to someone. So also remember that you should be doing what you're comfortable doing. So I think it's really important to say that if your work feels like it's re-traumatizing you, you have to pay attention to that. I am someone who doesn't work in domestic violence because of a family experience. And so it's really important that we know that, because I know that I probably couldn't be as open and present and person first with the perpetrator as I could be if I didn't have that same experience. So that's important. But so these stigmatizing thoughts that we have about other people essentially reflect this undesirable attribute that our society, or a portion of people in our society, usually the majority in society, have deemed as undesirable, unwanted. How many of you have ever read or seen the movie The Scarlet Letter, right? Or the word stigma comes from stigmata, right? The mark. So it is a mark that people wear. It is this kind of prejudice, this bias that becomes almost visible to the rest of society. And it's, oh, sorry, go ahead, Ken.
I was just going to add a piece about internalized stigma. Most of my work outside of the hospital is in addictions. I know very few people with addictions who don't carry some pretty serious negative self-beliefs. Mm-hmm. Some version of, I am not worthy of love. I don't deserve to be happy. I'm a piece of shit. Sorry, we're recording, but
it's okay. We can be real.
We're keeping that. They all carry that. So I believe that's a form of internalized stigma. So what happens when you have someone who has the internalized stigma already, and then you get it from the outside as well, and it compounds? It's bad enough when somebody calls you something, if it doesn't connect to you in any way.
But when you believe it.
Then it's a whole other.
Right. Absolutely. So it's like, it's different when I walk onto a unit. Well, I haven't been doing any walking onto hospital units in over 6 months, but it's different when I walk onto the unit and I had just lost about 70 pounds. Ken has been with me during my weight loss, and he really has helped me. But like, you're feeling good about yourself. You walk onto the unit and somebody calls you a fat, blah, 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 just because it's 9 a.m. They're being pushed around on the unit. They don't feel like seeing you, and they hit you with something, and you can kind of like detach from it. But when you really believe it, that hits you hard and it demotivates it. So this constant pressure, negative pressure from the outside world really does infiltrate a person's personhood, for lack of a better word. So a couple of the researchers that are more contemporary to us, which is Link and Phelan, they describe stigma as really this convergence of multiple components. So being labeled and being cast aside, then the dominant group decides, we're going to make it be known that people who act like you, look like you, aren't desirable in society. And then these folks are placed in the out group. So they're not included in decision making. They're not included in things that are about them, right? So there's a motto in the mental health community: nothing about us without us. So people want to be involved in decisions that will impact them, right? And then ultimately these individuals are labeled with status law, or they experience status loss, which means they are not viewed and held in equal esteem to folks who don't have that undesirable quality. So what happens then is what Ken was talking about. We start to integrate those feelings into our personhood and really feel as if we are less than, right? So the individual then integrates this into their experience and their identity, and they anticipate then negative social interactions when they interact with people of the majority in their community. And so then they may pull back, and may actually there may start to be this self-fulfilling prophecy of, see, I'm undesirable, nobody wants to be with me, and I'm going to also pull back, and so I am less desirable to the rest of society. But this eroding away of the person is very serious, and we have seen it in actually some of the research that I've been involved with. Internalized stigma has predicted lack of involvement in work to a much higher degree than somebody actually experiencing psychiatric symptoms. So somebody could be hearing voices, somebody could be having delusional thoughts, somebody could be depressed or anxious. But if they don't adopt the sick role through internalized stigma, they are much more likely to continue to work than someone who's experiencing less symptoms but identifies with the sick role, right? So we have to be really mindful of the impact of internalized stigma, and also recognize that for someone, you know, let's say I have a diagnosis of depression, but I'm still able to work and I'm still able to do some of these things. That's not necessarily reflective of my level of internalized stigma when interacting with other populations. So someone that you're working with who may be forensically involved, but may seem to not have a whole lot of psychiatric symptoms and all that, they may still be experiencing internalized stigma. And the way that that can be compounded is through what we call intersectionality. So this is a fairly new-ish term in the field of psychology, psychiatric rehabilitation, and social work. I think it's been kind of around for the last 10, probably more years for folks who are better versed at this area of research. But the idea of intersectionality is, you know, where some of these biases and stereotypes and discriminatory practices and labels intersect, right? So we know that people have been discriminated against based on race, based on gender, based on sex, based on socioeconomic class, and disability and perception of disability, and many other reasons. This is a graphic that illustrates where these things intersect, they also compound. So keeping that in mind for the folks that you're serving, and for some of us, we have issues that do intersect, right? In addition to your role as a clinician, your role as somebody serving folks in the mental health system, what Ken said about that inference of power, power is inferred in our relationships with people who are seeking help from us. We have to be mindful of the amount of power we have in that power. Ken, did you want to take
yeah,
this?
this is just a really quick, I mean, we could probably spend a whole lot more time on the concept of intersectionality. That's probably a training all of its own. And I don't think Dawn and I would be the people that would necessarily be giving it. There are people that know a lot more about it. I would start with Miss Williams Crenshaw's work as a start. But we are probably all familiar working in the mental health system with the stigma around people with mental illness. Well, when you throw on top of that other stigma and other negative beliefs about other groups that person belongs to, you know, whether it is a given stereotypes about a particular race, stereotypes about a particular sex, et cetera, et cetera, et cetera. So intersectionality represents this just additional weight that's put on a person, and they never know when it's going to come up, whether it's going to be around all of the time. And that also forms part of this hierarchy in corrections and in the forensic setting I was talking about. Very often people belonging to a similar group will band together. That's the safety in numbers. So Nick knows more about this than I do. That's why I'm pretending not pretending to be an expert in this subject whatsoever. However, we did want to bring that up here because it's often one of those invisible things that doesn't get talked about, but it needs to be talked about. And for me, I have to use the premise of stigma as mental illness, of mental illness, and then expand that and say, okay, well, now you've got that, but now you've also got this. Oh, and by the way, you've also got this. And all of these different areas form, remember we were talking about that power structure before? Well, guess what? Our greater society has a power structure just like that. And many of those rules of our greater society are enforced in these sort of settings, as we'll talk about. So Dawn and I were kicking this around because even just in the idea of the psychiatric hospitals where we work, there's a hierarchy there too. So you have people with mental illness. Where do people with addictions fit into that? Are they seen as lower on the hierarchy, or are they seen in some cases as higher on the hierarchy? Because they could say, oh, well, I'm just an addict. That's it. I'm not crazy. So now you've got that going on. People that have psychosis, people that have diagnosis of schizophrenia. For 20 years, I worked in emergency rooms working with people who were having their first break. And I tell you, if I had the choice between telling a parent that their kid had cancer and telling their parent that their kid had schizophrenia, that's a tough call. And I've seen both done, and neither one of them is pretty. It's pretty much everyone's worst nightmare. Speaks to the power. Some people don't even want to say the S word because that's how, the C word, people say that too. That's how powerful those words are and what those things, and part of that is what it means. In the terms of cancer, it means the severity of the illness and what people have to go through. In the case of schizophrenia, it has more to do with public perception and the stigma that's attached to it. So we talked about some of these other things, service frequency. People that come through regularly. In the emergency room, we used to call them frequent flyers. I'm sure that's a general term. Someone that everyone knows when they come in the door. We almost say they're part of the orientation process, but they get disregarded to a certain degree because they've been through the system so many times. Certain charges. In a weird way, the more severe the charges are, the higher you move up in the status. The murderers and all that stuff were actually, people who had committed those crimes were actually higher up on the hierarchy than people that were minimum security and under those sort of charges. Violence, we talked about. Geriatric clients, we are a pretty wicked ageist society here. We sort of disregard the older people. And I know Dawn and I, particularly the hospital that we work at, we struggle so that
We just had that conversation this morning.
back right now, where to get geriatric clients to have the same level of programming as everyone else is a huge struggle. Why is that? Do they need treatment less? Well, they're old. Ugh, you know. Personality disorders. How many times have you heard someone being referred to, oh, they're a borderline, they're an antisocial, they're a sociopath, they're a psychopath? But the intention of all of those is they are a blank. That means less, maybe less than human, certainly less than you. And then that's the jumping off point for, we're going to disregard this person's needs. You know, it's grounds for service denial, or even just denial of standard human empathy and compassion. Yep. So I hear the labels coming around. I can't tell you how many times we've seen someone who's had a first break, very often someone at college, they come into the emergency room, I'm meeting with the parents, they will look me right in the eye. Is it schizophrenia? You want to answer that question? Because that's a rough one. So in addition to the intersectionality that we already talked about, which I'll call the societal interactionality, for lack of a better term, and again, don't confuse me with the expert, even within the mental health system, we have that same thing added on.
Absolutely. Thank you, Ken. And I think it's really important for us to remember, and I mean, we all have our own biases, right, around the variety of things. So it's like really important. I think one of the things that Ken said is that we label someone and immediately they become different from us, and it makes it easier. And this is horrible to have to say this, but it's something we have to remind ourselves. As soon as we start to label, we're allowing ourselves to attach descriptors to those labels, and usually they're not good. And that's when it becomes easier to see someone as less than a person. So, you know, one of our challenges in this field is to make sure that we always remember the really bad things that have been done to people in institutions, in psychiatric care, and in justice systems, and always remind each other to support personhood. It's a very important.
And this is where our own experience with it has been very helpful. If we've ever been on the business side of this, if you've ever been on the business side of these judgments, that's an important lesson to hold. To me, it's one of these great ironies that very often people who've been on the business end of those sort of judgments, people who've been persecuted very often can persecute others. It's easy to pass that.
Hurt people.
People hurt people. Love it. So yeah, that sort of aspect of it. And it doesn't mean that's universal, but it can go that way. And I think the difference between whether it does go that way is that insight and awareness into, okay, how much this hurts and how unjustified that is. You're not going to pass it along to somebody else. So what we have here, just in a quick look, one of the things that some of the work that I've done at the forensic hospital and at the civil hospital was we compared the frequency of diagnoses to see how similar and how different they were, and to see what we saw more of in one place as opposed to another. So down the left-hand column here, you see the top 10 most frequent diagnoses in the forensic hospital. And then down the right side, you see the civil hospital, which it covers the same state. So the first two are schizophrenia and schizoaffective disorder. And I think that represents about 75% of the diagnoses in there. They're both pretty even in terms of frequency, but they're both 1 and 2 in both places. And then as you look down, probably not too much of a surprise that you see a little more antisocial personality disorder diagnosed in the forensic, but it is still pretty high. It's number 8 in the civil, so it's there. You see some of the substance use disorders are right up there. Cannabis and alcohol. Interestingly enough, cannabis and alcohol have switched places in the last couple of years. It was all alcohol up front, and then the forensic, they've switched. You see bipolar, you still see psychosis. So there's more similar than different, but you can see some of the differences here as well. Another interesting point on this, a very important point that I missed. Does anybody see post-traumatic stress disorder on any of these? I'll save you the trouble. The answer is no. PTSD is hideously hideously underdiagnosed at these facilities. I think when I did the original data collection, the civil hospital had 400 people admitted and had 5 documented cases of PTSD. And the forensic is about 200 people, and I think they had 8 or 9. So I'm going to leave to you whether that sounds like the world we live in or whether it sounds like there's some sort of mistake there. I'm under the impression that there are probably more people with PTSD there than without it. And if they didn't have it before they came in the door, they have it now.
And that's what we're going to transition into now, is this deeper dive into trauma and what people who are forensically involved or involved in the criminal justice system or have been may experience. And so what we've seen, and I'm going to guess that this probably isn't only being seen in the New Jersey state psychiatric hospitals, but probably in many hospitals, and not just psychiatric, but also general medical, we may be seeing people being overlooked for their trauma experiences. So as you see in that comparison that we did just a couple years ago, we weren't picking up on these trauma conditions very well. So that is one thing that we have to pay attention to, is that, are we detecting these potentially traumatic experiences that we know that they are having? Research tells us they are having it. Our anecdotal evidence tells us that we know that they're having it. We see it happen. Sometimes we don't ask it correctly, right? If we ask, have you ever experienced a trauma? Well, to somebody who maybe has experienced food insecurity and has been harshly disciplined by their parental figures most of their life, maybe they don't see it as trauma, right? So we need to ask about their early childhood experiences and what they've experienced throughout their lifetime, and less about was it a trauma or not, because a person may not have that insight, especially if the situation or experience has been normalized to them.
Yeah, I want to just go back a second because I feel like I slammed the hospitals, and part of that was justified and part of that is not. When people come into the state psychiatric hospital, very often symptoms like psychosis and mood swings, there's other symptoms up front. The trauma stuff doesn't necessarily manifest right at the door, so I will give the hospitals a little bit of a break there. The other part of that is that in an involuntary treatment facility, people aren't necessarily incentivized to talk about their trauma. They want to get the hell out of there. And that's fine. We like that. In fact, they don't want to share it because they're afraid it's going to prolong their treatment. At the same time, the hospital doesn't want to go there because they don't feel like it's their place to do longer term stuff. As the length of stay of the hospitals have come down, you don't want to be opening all these trauma doors. So on Tuesday, let's talk about your deepest, most serious trauma in your life. And Thursday, we're going to discharge you to the community. Not a great plan. So because the hospitals weren't planning on treating it necessarily, it became a don't ask, don't tell. But then the problem is readmissions. The people that are most traumatized come back the most often. So that becomes the problem with that philosophy. If you don't do it, this is true in life. If you don't do it right the first time, you end up doing it again. And that's what happened with the readmission. So I'm going to give the hospital a little bit of a pass. And I will also add, and I can't speak to the hospitals out by where you are, but I know in the New Jersey's case, we've come further in the last 5 years or so with trauma than we ever did before. Before Dawn started at our hospital, trauma, the T word was never spoken. Now all new employees, now we try to infuse it into everything.
Are you giving me credit for that?
No, you were
I'm
part of
going to copyright that, what you
go.
just said. Inside joke, guys, inside joke.
So it's getting better. Is it where it needs to be? No. And I actually think the frequency of diagnosis is an indicator of how we're doing. And the research shows that you can start at 60%. You could start at 60% PTSD and work your way up from there.
So, and to touch on that, I mean, the general population's incidence of PTSD throughout the lifetime is higher than what we're seeing in the state psychiatric hospitals. And that's not the general population coming to the highest level of psychiatric care, right? So it's pretty safe to assume that the folks that we serve are probably going to have a higher likelihood of having the lifetime prevalence of PTSD. So we just need to do better. I know you guys are aware of that, but we always want to reiterate it. And I believe that Donald made a comment about genocide and being faced with intersectionality when an individual has a mental illness or somebody is suspected of having a mental health crisis. And also that coming to the attention of law enforcement, right? So I will not beat up on law enforcement because they have difficult jobs. We also have to recognize it's a difficult job. And sometimes folks, it's, somebody presents in a way that does look dangerous, right? They may be lunging at others, or they may be looking like they're dangerous to themselves. And in that moment, it's really sometimes very hard to parse out what's happening. Which is why we need all this education, and we all need to be talking about this a lot more. And I really thank you guys for being those advocates for the folks that you serve. Really important to remember. So because what happens when we ignore trauma. So there has been this study called the help me out, ACEs, the ACEs study, Ken. Adverse childhood experiences. Some of you may have heard that. So the idea about the adverse childhood experiences is that we count the number of not so great experiences that you had as a kid. And we're talking about 10 items, things like there was a divorce in the household before I was 18. I witnessed domestic violence. I was sexually offended against, these types of things, right? And the more that you can check off as an experience that you had, there is a predictive element to it. The more likely you are, if you have had, the more traumas that you've experienced as a child before the age of 18, the more likely you are to experience some of these things. So 4 or more traumas in men, I should be specific, in men, are related to, at a very, very high power level, which means the chances of error are pretty low with this, an elevated odds of arrest. So 4 times, about 400%. 4.03 means 403%. Elevated risk of arrest for men who have 4 or more traumas. Elevated odds of incarceration in a jail, which again is a lesser level correctional facility, usually a county level, about 500%, and elevated odds of imprisonment. So at the state or federal level, about 2 times the chance. So as you see here, these early childhood experiences, and then also any additional lifetime adverse experiences, do have an effect, a predictive effect of interfacing with the criminal justice system. And I'm going to apologize because we have facts and figures here for Black populations and white populations. This is the data that was the most available for us. We're just using it to highlight some of the disparities, but definitely other populations, especially other minority populations who have experienced systemic racism for hundreds of years, will experience disparities as well. So we already know, research tells us that trauma disproportionately affects Black Americans, regardless of income level. Okay, so, and that's important to know. 1 in 5 Black children will experience maltreatment at some point in their life. That doesn't mean from their family members specifically. 1 in 10 white children will experience maltreatment. Again, not specifically by their immediate social circle. And nearly 9% of Black adults have a lifetime history of PTSD as compared to 7% of whites. So that figure is a little bit more close. There's a little bit less disproportionately represented. But when you consider that whites are the majority population, I think still in the United States, it is disproportionately affecting Blacks. So again, remembering what those traumas can be associated with at a level of involvement with the criminal justice system later in life. So, and then regardless of race, a lot of people do talk about socioeconomics in a lot of ways as being this great equalizer. I don't completely buy into that, because I still think that as a society, what we wear on the outside, unfortunately, does bring with it, disparate interactions with others, and people still fall victim to racism and so on. But regardless of race, individuals who live in an urban, low-income community, and this is one of ours local to Ken and I, in Camden, New Jersey, folks experience greater rates of lifetime prevalence of PTSD at about 25%, which is still higher than the general population. So you saw those other general rates for African American and Caucasian populations were around 9 and 7%. But for the residents who have grown up who live in lower socioeconomic neighborhoods, that also brings with it a lot of other challenges: food insecurity, greater prevalence of crime in the neighborhoods, greater presence of law enforcement in the neighborhoods, physical health conditions, smoking, some other doubling up. I live in a multi-generational household. That was traditional in my very German family to do that. And it's actually tradition in many other communities, and it may be necessity in other communities. But with that also brings other challenges, some of which we've saw during the COVID crisis, which has been a greater likelihood for people to get infected or be affected by communicable diseases as well. So there are challenges that are endemic to just even living in a lower income community that are regardless of race. And then race can compound, as we saw in our discussion of intersectionality. Ken, I think you wanted to say something. I'm sorry.
Jump in with two things. One is the frequency of police contact, and the other one is the nature of police contact. The only experience that I had with a police officer, I got a ride in the back of a police car. There was a blizzard in our neighborhood, and I was walking home, and the officer gave me a ride home in the car. I am sure for everyone that is not the first experience that they've had with police. So there's the frequency of that contact, and then there's the nature of that contact, where it can just be seen as more automatically more adversarial, from both sides.
Yeah, absolutely, which is why there's such a big push. Actually, Camden, New Jersey, where this picture is from, absolutely, with any urban community, there are these beautiful areas that you would never, like Rutgers has a campus there, beautifully manicured, beautiful. You would never think that you step 2 blocks off that campus and you see like SWAT teams. And I mean, it's scary. And I just get scared by the militarization feel of the neighborhoods, not as much about like some things, debris flying down the street or something like that. But it's just that feel that you get when you come into the neighborhood, that it doesn't feel so welcoming, right? And so the folks in that community, we wonder what it feels like to actually have to live there, right? And have folks be afraid to come in, and that's not necessarily because of activities in the community, but how it is policed and viewed by people in general.
Great point by Sherry in terms of the speed of intervention. The further someone gets into a process, the harder it is to get them out of it. So that's why I love the community part. If you go out with police right at the point of, that can prevent a charge, which can prevent an incarceration. So the sooner you get to it, the more help you can actually do, as opposed to, and I did this job in the jail, assessing people when they came in. we were assessing them for suicide risk because they'd had a bunch of completed suicides in the jail, but also it ultimately took the form of diversion. But once you have that charge, it's hard to back out of the legal system. It's sort of a one-way street in, and then there's a quick loop to get back in again. So that's a really good point. The faster, the sooner it gets done in the process, the more trouble you avoid later on down the road.
Sorry, I got a little slide happy. And yeah, that I would say that goes for the psychiatric system of care as well, Ken. I think that we have seen, and we always advocate for people to try to go voluntarily into a hospital. And it's not because we want them to make our jobs easier as psychiatric screeners or people working in emergency rooms, but it's because once you get to that really high level of care, whether it's in the psychiatric system of care or in the criminal justice system, like you find your way into a jail, like Ken says, it's hard to back out of that. And it seems like that groove is then, that track is set for you. When you then interact with law enforcement again, they know you're that guy or you're that gal I had to take downtown before. Or, at the psychiatric screening center, you're much more likely then to return to a higher level of care than maybe what you need locally. So having that community level advocacy and interaction with psychiatric professionals and with community policing is very important. So something that we've also seen that could be why folks are seeing more and more individuals involved with the criminal justice system is this wrong type of population growth over the last, I guess almost 50 years now. But since 1977, these figures were from 77 to 2005. So they could be a little bit more scary, or maybe they've improved a little bit, but between 77 and 2005, our population of individuals, of citizens that were incarcerated rose by 400%. Most of that due to sentencing reform in the 80s and the war on drugs, which has disproportionately affected people in lower income communities, people in the minority populations. And, so say what we want about the war on drugs, we do see a correlation between it, sentencing reform, and our incarcerated fellow citizens. So I'll just leave that there. And it has significantly, disproportionately affected people along racial lines, especially Black adult males, who 20 to 30% of Black adult males in the United States will have been incarcerated at least once by midlife. And that is a scary figure, but it is a true figure nonetheless. Versus 4.4% of white adult males who will be incarcerated at least once by midlife. So, this is really something that we have to keep in mind, that historically, people have been disproportionately affected for a very long time, and still. So, I think that this information is, somebody just said a for-profit prison system. Yeah, you're absolutely right. So when there's an incentive, as many of you may know, there are for-profit prison systems. I wholeheartedly believe there should be no for-profit education, no for-profit healthcare, and no for-profit prisons or nursing homes. That's just my opinion. Because these are vulnerable populations, right? No matter what our feelings are towards people who may have committed crimes and so on, these are vulnerable populations because of the power differential in these facilities. And so this is something we need to pay attention to, and something that I think is a very important and an educated talking point for those of you who are doing advocacy on behalf of your clients. Ken, did you have anything else to say about?
I'll pile on to share.
Maybe the cocaine.
Oh yeah, two things about that. One was the idea that crack cocaine was actually punished at a higher rate than pure cocaine. So even though the cocaine was degraded and added, baking soda and all this other stuff, people were getting punished at a higher rate for that than they were for pure cocaine. So now it reflects which population is, using one, which is using the other. One is primarily affluent, primarily Caucasian, other one not as affluent, more African American, and that's kind of how that went. There's also some interesting work on that area on the marijuana laws of the good old days, and now that's sort of reversing as well. I also wanted to pile on to Sherry's point regarding the jails. Another work I did was what charges people were there under. 8 of the top 10 charges in the county jail were drug related. And one of the 2 outliers was failure to pay child support, which I'm guessing if I'm addicted to something, I'm probably missing child support payments. So it became pretty obvious that the county jail was the only inpatient alcohol and drug provider in our particular county, because our medical unit was all for withdrawals. So you had a whole block of the medical unit, which was just to detox people when they came in the door. And detoxing was, if you were lucky, you had a mattress. If not, you were on a concrete floor. And it was about 55 degrees and you weren't getting any medication. So that was kind of how that went. So it was 2 or 3 days of the shakes, hopefully just the shakes, and then we go from there. So 100%, I agree 100%.
And like Ursula just mentioned, that it's also relevant that the likelihood of incarceration does not correlate to crime rates. Right. So the crime rates are not necessarily higher among Black men, but their incarceration rate is disproportionately higher. Yeah, absolutely. So, I think that these are things that we have to keep in mind, especially those of us who are in and I hate saying it this way, the majority population. We have to do this digging. This kind of information isn't like spoon-fed to us. And so it is, as professionals in this field, we have to educate ourselves so that we're able to look at things objectively and look at why we see African Americans as who we see in prisons. And it is important to recognize that, the crime rates aren't disproportionately higher. The enforcement of a lot of these punishments or a lot of the consequences are disproportionately also used. So that's an important note.
Wanda asks a good question as well that I don't know the answer to. I will say that the opiate situation is a little complicated because you've got the street version, heroin, and then you've got the prescription version. In actually right by Camden, where that picture was before, there's a very affluent suburb called Cherry Hill. And in Camden, we had lots of African Americans that were using heroin, and we would see them in that emergency room. Not even 5 miles away, we'd be seeing lots of rich white kids in the emergency room using OxyContin and all that kind of stuff. So that one's a little complicated, but it's definitely worth looking at the research. But we can also see how the legislation follows.
Excellent point, and thank you, Wanda. You guys have had some great comments and questions. We love it. Keep it up.
I got to look that up.
Now we have to look it up. We have homework. Ken, is this one you or?
Oh, I'll take it. I'll take it.
Okay.
So this is some work that we've done in the state hospital quite a bit, studying the different types of violence, because obviously we want to prevent violence and we want to mitigate it and prevent it. So this is something that a colleague of ours, Tom Bartholomew, has been very into for a while. So the 3 types of violence. One is instrumental violence. This is more the violence among a forensic nature. It's planned violence. So it's violence to achieve a goal. If any of you guys are familiar with the movie Office Space, I'm a huge fan of that one. Notice how this is turning into movie time, but these are great movies. There's one scene where, no spoilers, but there's one scene where they're speaking to a lawyer and the lawyer talks about what you have to do the first day in jail. So intentional violence. I'm going to commit an act of violence to secure my status. In the hospitals, we see it happening with contraband. If someone gets to go out into a community visit, they say, okay, you got to bring me back a couple pack of cigarettes or something bad's going to happen to you. So that's an example of instrumental violence. Psychotic violence is violence that comes from psychotic symptoms. If you feel like someone's following you or that they're going to hurt you or kill you, the devil sent them, then that's the violence that comes from that. And then the third type of violence we see is reactive violence, which is something that happens just in the moment. A person gets bad news, and I think this has more to do with coping skills, where they get bad news. Oh, you're not going home Friday. Kaboom! Someone isn't coming to visit you, and it literally, the explosion happens within 5 minutes of getting this news. Very often the person might be sorry afterwards, but in that 5 minutes, it happens. Next slide, please. And then here's how this actually falls out. And I don't know, this might be a little surprising. It was to me when I saw it. So here's the percentage of violence that we see in forensic hospitals and in civil hospitals based on these three types. So here's the instrumental, organized, revenge, predatory violence. 29% in forensic, 20% in civil. So you see a difference there, but to me, they're both lower than I would have expected. Psychotic violence, delusional in nature or due to hallucination, something along those lines. 17 and 15%, very low on both sides and almost identical. And then the last one is reactive. This is that impulsive reaction to something. And these numbers are much higher, 54 and 65%. So what we found on the hospital side, and I would ask you to think about this in the setting where you are, where there is an episode of violence, what type is it? Because it's really easy to just say, well, that person has schizophrenia, so this comes out of that. And we find that that isn't really always the case. It may not be based out of symptoms. One of the reasons that the psychotic violence may be so low is we're treating people with medication. You can medicate that. It's much harder to take medication for intent, like in the instrumental violence, and harder to use medication as a replacement for coping skills. Okay, I've just gotten some bad news. What am I going to do? Am I going to react in a violent manner? How am I going to deal with it? But of course, diagnosing what the nature of the violence is the first step toward intervening effectively. I know in emergency mental health, we medicate everything. So that's not really good. If someone's upset because they just lost someone close to them, maybe medication isn't the first place we want to reach. So it's really more movie references. I haven't seen that one, I must confess. So, all right, I have more homework now. But I've heard it's great. So again, diagnose the type of violence, and then that points you in the right direction of the intervention. And you notice that this is not diagnosis specific, because again, people with a mental illness have the right to participate in have to be affected by these other types of violence as well.
And I think that I hate to say the wonderful thing about the fact that reactive violence is the highest category, but the wonderful thing about reactive violence being the most representative of all three types of violence is there is something that we as practitioners and as service providers, we can play a role in mitigating some of that actual experience of violence from happening.
Also, a good point on this is we're getting back to our point about the forensic stigma. See how these are much more similar than different? I know if you had asked me to fill these boxes in with percentages instead of using the actual research, that would have been a really bad idea. I would have said in a forensic hospital, the instrumental violence would have been the highest, and probably the highest by far. I would be wrong. And I probably would have put the psychotic violence a lot higher on the civil side. I would have been wrong a lot. So again, and I have to tell you, part of that is a lack of knowledge on my part, but also would part of it be bias? Truth be told, yeah. It's just easy to go there. There's lots of instrumental violence in forensic settings. What did Colbert used to call it? Truthiness. It wasn't how right something was, it's how right it sounded. So yeah, that would be very truthy, but not true.
Excellent point. So what do we do with that? So knowing that when we interact with people, we have the opportunity to either increase a person's frustration, or maybe we have the ability to decrease it. And, unfortunately, human behavior isn't the only thing predictable about human behavior. Sometimes it could be kind of unpredictable. But the fact that all of you do have probably a great skill set already on board, and and you have a relationship with a lot of your clientele that goes beyond just niceties, it does allow us the opportunity to kind of reframe the person's experience what they're experiencing in that moment, and to be able to provide them with the support, with the validation, with assistance in problem solving that they may not necessarily have internally, because they haven't developed the appropriate coping skills or problem solving skills. So one of the things that it's important for us as providers to remember is that when people experience, especially these early traumas, their ability to develop healthy coping skills can be stunted, right? So, but take myself as the example, and the person who likes to go turn to Ben and Jerry's and pizza when she's stressed out. That poor coping skill, that maladaptive coping skill, started to develop when I was 4 or 5 years old, like around the time when I was experiencing some of these difficulties. So we have to remember that the folks that we work with in front of us may be 35, maybe 45, maybe 65, but they still may be using some of the coping skills, maladaptive coping skills that they acquired throughout their lifetime, which has gotten them into some bad interactions with law enforcement, with healthcare systems, with their peers. So we need to validate what the person is experiencing. We don't have to understand it. We don't even have to necessarily agree with what their perception of the experience is, right? There have been times when I'm sure you've interacted with clients when you just know they're wrong about something and you know you're right. There are times when you've interacted with friends and family the same way. But very often where that's going to get you is into an argument right off the bat. And that's not what we want, right? We want you to be able to understand, to accept what they see as their experience. Oh, you don't have to necessarily challenge it or confirm it, just to understand and offer empathy and allow them the ability to express their frustrations. It would be very easy to say to someone, well, of course you didn't get that apartment. You're a registered sex offender, right? Of course that landlord doesn't want you there. Hey, I'm a parent. I don't know how comfortable I would be, given your history or whatever it might be. We don't have to necessarily disagree with the enforcement of a law or anything like that. Just have to get what it would feel like as a person. Explaining the current circumstances, what the restrictions might be, why a decision may have made, why it didn't work out in the person's favor in a way that is objective and without your own slant, right? Just the facts. Because one of the things that happens with people when they're feeling reactive and not so good about the object of their anger is that they feel that sometimes maybe the law or the rules were unfairly applied to them and not others. So some of this that you guys and ladies have been bringing up, this unfair application of rules and laws in our society, is what many people, a huge portion of our society, have been feeling for hundreds of years. So that is very important to keep in mind. And if you're an individual who is working with folks who have been systematically oppressed, we need to remember that we have not, if you have not, like I have not, shared that same experience. We need to be mindful of that and respect it, even though we may not have experienced it. We need to be mindful that it's a true experience. And then we want to partner with our clients to problem solve, right? We may not be able to we can't fix our clients' criminal history, short of helping them to expunge things, which is something that I did in my old job, expunge records so that they could vote, so that they could, that was the biggest thing. People wanted to vote that I was working with, but they were convicted of felonies. And so this was the number one reason for me helping people to expunge their records, which were almost always drug offenses, drug use offenses, not distribution. And in all cases, the folks were African American. So I'm going to leave that there. Yeah, Ken.
To add on to that, I don't know how it works in Washington State, but in New Jersey, if you were convicted of a felony, you were now ineligible for any sort of public assistance whatsoever. So there were entire homeless camps, including an entire tent city outside of Lakewood that was completely comprised of people who'd committed drug felonies. Now, the line between felonies, another one of those interesting areas. If you sell a drug in the wrong place, it's now a felony. If you have a certain amount on you, that moves you into a felony. Well, what if you're a heavy duty addict and 15 bags is what you use in a day? You get nailed for distribution, it's a felony, even if that was all yours. So that these are some of those other, like a chutes and ladders thing that leads you a little further into the legal system. So that's one of those motivators, is you got to get that felony thing off your back, because otherwise you can't get any assistance going forward.
Absolutely. Thank you for adding that.
Mm.
So with that being said, we're going to go ahead and leave the rest of the time. We have about 20 minutes. We want to go ahead and leave it open for any questions or discussion that you guys would like to have. I think we had a pretty active chat here.
I like that. If I could just add one more point before we go into the Q&A, because we had talked a bit about strategies. So we did the CBT thing in the beginning about adjusting, knowing your own trauma, looking at knowing what your own automatic thoughts are. And then the third one, I would have to say the thing that's been most helpful for me in this area is using trauma as a default. That I automatically assume that someone who has gone that far in the legal arena, addiction arena, has gone through some sort of heavy duty trauma until I can prove otherwise and find out otherwise by interacting with that person, because that stops me from leaping to a more critical judgment. So to me, it allows me to give the person the benefit of the doubt until proven otherwise. Then the relationship will prove where it goes from there. So to me, that's been a really big piece, is to look at, all right, so what trauma have they been through? They might not even know it. In some of the environments that Dawn described, what we would consider trauma is so normalized that it's just the way it's done. So that to me would be the other strategy, is to do this sort of cognitive restructuring thing where I automatically use that trauma place to jump off from and then go from there, as opposed to looking at a criminal origin, having that as the etiology of it. Oh, and thanks for the link to that website. We talked about this before. We have our project has a website with at least 25 different videos on it about all sorts of things. And there it is. If you want to hear other stuff like what we're talking about. So I'm sorry, that was the last thing I wanted to get in there before we get into the Q&A. So fire away.
Yeah, so let me give you guys a very quick little tour for our website. This was something that we put together in early April when we got thrown out of the hospitals on March 13th, I think it was, when our emergency declaration was declared by the Honorable Phil Murphy here in New Jersey. He called us all knuckleheads and threw us out of the hospitals. He's I don't know if you guys have noticed this thing about New Jersey governors. They talk just like we do. So if we drop some cuss words in here, we're very sorry. We're being led by example. But so this is our website. Of particular interest to you guys would probably be where you see next to home, online training and surveys. There's some surveys there you can ignore. But there's a whole slew of online trainings, most of which you'll see Ken's face on. And so there's a bunch of them there. Most of them are fairly short in duration, so they could be like quickies that you just pick up and watch. So, they are there for you. There are some other resources here specific to some of our academic programs. If you're interested, calendars, events, they're mostly reflective of the work in our state hospitals, but definitely you could access that training section.
And we're open to suggestions for more material. If there's something we haven't thought of, we will either do it or we'll find somebody that knows something more about it than we do and get them to do it.
Right. So anything else? Does anybody have any comments, questions, concerns, things you might want to see on this topic moving forward? Or any trainings in general? And Donald also brought up an excellent point about folks who are incarcerated and have schizophrenia, one of the psychosis diagnoses, and may also have a felony or another conviction where violence was a component. So maybe they got into a fight, or they were paranoid and they fought back against somebody who wasn't, really aggressing towards them. So these folks also, they get labeled, right? And so when they come into even hospitals for care, we now know of them as the person with schizophrenia who got violent. and ended up in jail or ended up in the hospital. And also, you know, they are seen as unpredictable and maybe dangerous when they enter the prison system as well. So folks who have that experience with having a criminal justice history, and who may also have something that society views as a scary disorder, that's where those distinguishing characteristics intersect. So that's a great point, Donald.
Yeah, I just wanted to follow up regarding the psychosis reach. I'm not that familiar with that. I actually just looked it up while we were talking. That I guess the systems for families are different in each state. Here, NAMI has a lot of stuff that they do with families, and there's something called Intensive Family Support Services, or IFSS, and it's groups of families, but also in league with clinicians, because Donald's point is absolutely right. The families are very often the biggest missing piece in this. And maybe the family, maybe it has something to do with the family, either structurally or there's stuff going on there. And sometimes it's just the family's lack of receptivity to the family, you know. And I know in screening, many times you get family members calling, and if the person doesn't want them to know anything, you shut them out, even if they live with their parents. So, and I can tell you, I have a private practice, and working with families of mentally ill and addicted adults is one of the fastest growing parts of that, because it really isn't covered very well. And that is part of the person's recovery. It's a vital part of it. If those people are physically still there, it is critical.
Well said, Donald.
You know.
Very well said, right? So when we work in the field, we're always so excited and sometimes scared when we see a family is involved with our client, right? Because as you said, like, we don't know what the family system is like. So like, is this person now homeless and addicted and depressed because like they came from this really dysfunctional like family unit, or like is the family like, you know, great supporters? And so there's kind of that dance figuring out like how the family will fit into this person's recovery. And so that's why it's so important to form that therapeutic alliance as quickly as possible, so that the person can talk about the role that they want or don't want their family to play in their recovery. And Sharon asked a question about how can we as a business not be biased? So considering the example of a person not getting an apartment for being registered as a sex offender, how can landlords not be biased? Well, we can all be biased. So I don't know how we make landlords any less biased than us, but I think that, so one of the things that we have seen in the research is that education, and more than education, exposure to people tends to be one of the things that lessens our prejudices and our negative biases. That's a little difficult when we're talking about you know, working with a landlord and working with individuals who may have a registered sex offense or some other kind of violent criminal history. But I think that we still have to do the education piece. And, you know, obviously landlords can screen people out based on criminal history, but they have to apply it equally. So unfortunately, as advocates, we're sometimes in that very precarious situation of advocating for a client, informing landlords of laws and rules, and also being understanding to the landlord and how they want to protect their other residents. I don't think that I have an easy answer, Sharon, other than the continued advocacy and their experience with other folks that you may be serving. That they will see that you're responsive whenever there's issues, that you set up communication plans and so on. But I don't think that I have the magic bullet answer. Ken, do you?
No, I wish.
Sorry.
I just thought about it in terms of, you know, again, the trauma approach to me, the way I try to think about it and then also explain it is, whatever that person did worked for them in the environment that they were in at the time. But now they're no longer in that environment. So now it's just a matter of, okay, how do we learn to operate in this setting? I mean, to me, that's part of where this goes. We learn what works, no matter how the behavior may be repugnant or bizarre to someone else. It worked. It did something for that person. And of course, the key to getting them to stop that behavior is to realize that, okay, it doesn't work now. It's causing you and others more harm than good. So that's it. But you know, there's a short list of things, and I see them popping up on the screen now. If I'm a landlord and somebody has an arson charge, my first thought is, what am I, stupid? You know, and again, I'm saying that bluntly, but you know, that's how that is. And with sex offenses, particularly, there's what's affectionately referred to as the ick factor, and that's significant. That is a form of stigma. One of my other specialties in private practice is working with people with sex addiction. Did anyone in the room just go ew? Because somebody did. Probably many people did. Because again, that's the stigma that you know that comes along with that. But guess what? Many of those people come from trauma-filled backgrounds. They learned some really maladaptive stuff. It worked at that point in time, but it doesn't now. But they're still doing it despite the horrific consequences. So to me, that's the process. I think if we start by getting it straight in our own head and then expand it so that it works in our agency, then I think it can move out from there.
Yeah, I got another question from another participant who asked about community partners who are having difficulties working with people who were previously forensically involved. So again, that question about property managers and so on. It could even be other providers of care. So, you know, volunteer agencies and things like that. I would say as we've already said, probably education. And I think that the only thing that starts to really change people's perceptions is positive interactions. You know, I as a young provider in the field was terrified of working with people who had sex offense histories until I realized that not all sex offenses are created equal. Not all people who engage in sexual offenses are equal. And, you know, the tiers, even in New Jersey, don't make a whole lot of sense. We have 3 tiers, and it just so happens if your victim happens to be of the same biological sex as you automatically get tiered higher, regardless of what the crime was. So like these are things that are really important to recognize and to be able to articulate and also explain kind of the safety nets that you all serve as. And I don't mean to like put yourself in the position of saying nothing bad will ever happen. This person will never ever commit a crime again in their lifetime and will be a perfect tenant. But the individuals that you're serving now have a whole heck of a lot more resources than they probably did when they offended or they did whatever they did that caused them to interact with the criminal justice system. So I think it is important to capitalize and to really articulate all of those services that you are all providing when you do interact with landlords and property managers and other community partners, so that they do know this person is really in the best position to be a tenant right now than they ever have been in their life. And I'm not, you know, I hate to say that money talks, but sometimes it does. If a person has some sort of rental subsidy, I'm not sure if that would be the case with someone who has certain histories, certain criminal histories. But also that guarantee of about 70% rent every month seems to sometimes help. So that in conjunction with kind of the clinical case management safety nets that you all provide can be helpful.
A great point. Going back to the sex offender piece, we at the hospital where Dawn and I work, we had about 42 people that were listed under Megan's Law, and Megan's Law is the Jersey way of putting it, guilty of child sexual offenses. So we go into the building where most of that particular, of course, they have to be housed together for the most part for security reasons, obviously, and because of the stigma of their charges. And then, so when I go over there to see them, I again have the same moment that I had when I walked in the forensic hospital. They were not what I was expecting to see. I'm looking at very many scars from the TBIs that they've experienced. Some of them are people with intellectual disabilities. So even within that category of sex offender, there were a lot of different subcategories that I really wasn't expecting. I was thinking straight predator. I mean, I'll own my, judgment going in the door. And then when I saw them, it was completely different. So even just being able to educate, some of these people had offended with someone that they resided with. It was the only person they had access to. and again, I'm not minimizing a sex offense, but they're not all the same. So obviously some of it is who you have and who you have to work with. But part of intersectionality, as we talked about earlier, is taking this group of people and saying they are this, they do that. If you can start to separate that out, I think the first step of that is that not all of any group of people are the same.
Absolutely. Absolutely. Because an individual could be tiered as a sex offender because they relieved themselves in a public park where kids may have been around, right? And I've encouraged my son to do that a couple times when we were out and we're like on the side of the road and we missed the rest stop again because he said, no, I don't have to go. And then as soon as we pass it, he has to go. But so you think about these things, right? My son also looks different than a lot of people who are being charged and wind up in our criminal justice system. So these are the things that we all have to remember, that we don't know all of the circumstances that were happening which led this person to interaction with the criminal justice system, and nor should property managers or others assume that they know also what happened. But you know,
The difference between somebody who gets nailed for a porn possession as opposed to actual physical contact. Now, again, we can all look at that and go, oh, that's all not good, but they're not all the same either. Somebody who's addicted to child pornography isn't necessarily the exact same as a population as somebody who's going to go out and actually offend with a child. So there's all those little different pieces.
thank you, Ken, for that.
It is a slow go though. That one's not going to turn it. The ick factor is real and it is significant.
It can be, yeah. So we only have a few minutes left. We're going to go ahead and start wrapping up. I want to thank everybody for attending today. We do have our list of references here at the back. So you will receive the PowerPoint and you will also get a link to the recording. And then it will, I think, stay live for about 30 days or so, but you could download it to your device should you choose to do that and keep it in perpetuity. And probably at some point a version of this will also be available on our website. Okay.
We're trying to put everything up there so everything is in one house. Those of you, we were talking about families before. There's a video on there called Helping versus Enabling. That one is designed specifically for families. So I would love feedback on that one. So if you get a chance to check that out, I think that might be something that's kind of similar to that. We sort of kind of went on a tangent over to that, but that's a really critical piece.
Oh, thank you, everyone. We really appreciate all of the positive support. And we look forward to seeing you again soon. Again, if there are additional trainings that you're interested in specific to this population, specific to this topic, please feel free to reach out to us or reach out to your partners there in Washington at DBHR. And we'll be seeing you again soon. I think the next presentation will be middle of November, and I don't quite know what that's going to be yet. So, but you will see an invitation soon. Thank you all. Have a great rest of your day.
Take care, all. Thank you. Thank you for all the great feedback and questions. That was wonderful.
Bye.